Welcome, dear friends. I'm Dr. Manjunath. I'm a pediatrician and allergy specialist based in Bangalore. Today, we're going to look at a very important topic, and that is the asthma attack. They're frequently mismanaged, haphazardly managed, and children end up in too many troubles following this. So, this would be the topic for today. By definition, which is taken up from GINA Guidelines 2021, an attack or a flare-up or an exacerbation is an acute or subacute worsening in symptoms and lung function from the patient's usual status. Occasionally, it may be the initial manifestation of asthma. So we need to be very vigilant, and we need to prevent the asthma attacks from happening. So let's discuss this by a case-wise scenario. So here I have a boy, Mohit, who is about, let's take the name as Mohit, who's a 6-year-old boy. This is a very young, energetic boy, decides to help his mom during the Diwali preparations. And as we know that he is a known visa and he has a written asthma action plan. Despite all this, he lands up in emergency. Here we have a mother who's very smart, she knows what to be done at that time. She ticks all the check boxes what is to be checked. One thing, Mohit is on regular budesonide as prescribed by the pediatrician. She monitors all the symptoms: cough, breathlessness, nighttime waking up, limitation of activity. She also makes sure that she gave 2 doses of salbutamol repeated 3 times. She also added a prednisolone for the rescue, and then she decides to meet a pediatrician in the emergency. What would you do? Type all the answers in the chat box. We will discuss what's to be done in the next phase. First and foremost is we need to take a good history. The onset. How did it start? Was it a sudden onset or a chronic onset? Did it take a much longer time or a short time? We need to take all of that. And we also need to take the duration of the onset of illness. If it's a long-standing illness with a sudden flare-up or a sudden flare-up, or what sort of situation she landed up in that trouble. And is there any previous controller usage, and how is the response to that? If there is any reliever taken, what's the response to that? Are there any triggers for this particular event? And were there any flare-ups in the past which worsened his situation? Did he land up in any emergency? Did he go to any ICU? Were there any admissions in the past? We need to look at all these questions in a brief period. Take a couple of minutes to take a good brief history. Upon examination, this boy has a respiratory rate of about 28 per minute with a minimum accessory muscle usage. He was comfortable. He was able to talk in short sentences. He was able to talk in proper sentences. And on examination, we also find there was end expiratory wheeze. And oxygen saturation was 96% in room air. So, what would we do? How would we grade Mohit's asthma attack at this point, and how would we manage him? So we have a modified pulmonary index score where the weightage is given for the respiratory rate, wheezing, and the accessory muscle usage. For children less than 6 years, we have a different set of numbers, and for children above 6 years, we have a different set of symptoms and the numbers. Here, who's a boy of 6 years plus, and his respiratory rate is 28 per minute. So he would have a pulmonary index score of 1 for the respiratory rate, and he has a end expiratory wheeze, which again makes it 1. And accessory muscle usage was just minimal. So in this case, his pulmonary score goes anywhere between 0 to 3 or maybe 3. So we categorize the children as per the pulmonary index scores into mild, moderate, and severe. Any child who has scoring from 0 to 3 is the mild case. 4 to 6 is moderate, and anything more than 6 is severe. Mohit falls within that category where the pulmonary index score is around 3. So this guy can be managed in outpatient basis. For children who have a scoring 6 and above, should preferably be managed in a ICU setup. And how do we manage this in the primary care center? So we need to give continuous salbutamol inhaler 4 to 6 puffs every 3 to 4 hours till symptoms subside. Then frequency can be reduced. Okay, we also need to continue oral prednisolone. That's about 1 milligram per kg per day for a span of 3 to 5 days. And we need not taper the dose of prednisolone if given for a period of 3 to 5 days. If it is considered beyond 5 days or 7 days, then we have to consider tapering the dose of prednisolone before stopping it. And inhaled corticosteroids, that is budesonide, dose increased to 200 mics. Now we had given a dose of 100 mics for his continuous management. Now we have increased his dosage to 200 mics twice a day for about 2 weeks. So this would be the initial management in the primary care center. Then Mahitha is asked to come back after 4 days. Mahitha is another girl, the elder sister of Mohit. She's 9 years old. Her mother, who's a very smart mother, she calls you up in the middle of the night saying that she's rushing to emergency once again. You rush in to see her, and this girl has a respiratory rate of 40 per minute, and she has suprasternal recessions, and auscultation reveals wheeze throughout the expiration. So in this case, we need to assess the severity and manage. How do we do that? In this case again, the respiratory rate has gone up. So the score also goes up. From score of 1, the score has gone up to 2 in terms of respiratory rate. And the wheezing is expiratory wheeze. And there is apparent usage of the accessory muscles. So her score is anywhere between 4 to 6, which is again a moderate case. So this can be managed in a ER. So in the ER, how would we manage? So we need to give the SABAs or the short-acting beta agonists. We have salbutamol and levosalbutamol for our management. If on examination the saturations are above 92% on room air, we need to consider giving MDI with spacer. They might be having already at home. They will just get it, probably use the same thing. 4 puffs every 20 minutes for 1 hour. Do that, repeat it. Only 1 puff at a time. So 1 minute interval. If the saturations are less than 92% at room air, we need to give oxygen-driven nebulization with short-acting beta agonist. 3 times at 20-minute interval. So if steroid has not been started, start it. If the child has already been started with prednisolone, continue prednisolone. And we need to continuously assess this child for next 4 to 6 hours before we actually send them or shift them to ICU. And if the response is good, if the pulmonary score goes less than 3, decrease the nebulization to 3 to 4 hours interval. So in this case, Mahitha doesn't respond and her respiratory rate has gone up to 48 per minute from 40. You have admitted this child to ward. What would be the plan? So we basically divide that again into the oxygen, steroid, IV fluids, nebulization, and we can also consider adding ipratropium bromide. Monitor saturations and the pulmonary score assessed frequently. We also need to consider getting the CBC, potassium, chest X-ray to identify if there are any complications. If we give so much of nebulization, we can expect some amount of hypokalemia to happen. So to monitor The potassium levels are very important to prevent those arrhythmias from happening. So, what next? If improving at this therapy, how long do we wait? We wait till the pulmonary score reduces anywhere between 3 to 4, and we then consider discharging the child or tapering the dose or whatever we want to. If the child is worsening with this therapy, we need to intensify the treatment. Before we intensify the treatment, all the advised treatment on oxygen should be monitored properly. We need to make sure that the enough oxygen is being driven through the nebulization and oxygen is being given. The nebulization is done properly and she gets adequate IV fluids and steroids adequately. Ipratropium nebulization done thoroughly. All that has to be monitored before we even consider stepping up the treatment. And she, in this case, Mahitha lands up in ICU. So we need to consider magnesium sulfate, terbutaline, IV aminophylline, and we also need to consider blood gases, and we have to shift her to PICU. If there is no PICU, make sure that she goes to a place where there is PICU. So in this case, in this talk, we are not going to deal with the ICU management in detail. We'll not do that. We'll restrict a child who is coming to OPD or probably the emergency ward, going home or going to ward. And another question what your junior resident asks you at that point is, antibiotics, why haven't you started antibiotics? Is it not needed? What would you answer to your juniors and your colleagues and even the parents? Many parents still ask, why not antibiotic? We need to answer first in our mind, and that is antibiotics have very limited role. Consider only in those patients who have purulent secretions and evidence of bacterial pneumonia. Viral infections are responsible for more than 90% of those events. The rhinoviruses are commonly the ones which cause the wheeze attacks in the preschool children. Along with bacteria like Streptococcus pneumoniae, Moraxella, and Haemophilus influenza can also cause those symptoms, but it's mostly the viral infections which trigger an event of wheeze. The mechanism why it happens is very unclear. The affinity of viruses to specific receptors in bronchial mucosa is one possibility, and bacterial infection after local immunosuppression by viral infections are few possibilities. So there are few medications which have no role in asthma. One is a mucolytic, a cough suppressant, a sedative, chest physiotherapy, and steam inhalations. These do not have any role in asthma management. So I have seen many prescriptions where they have written the cough suppressants. They have absolutely no role in that. And sedatives, they're going to worsen the child's situations. Keep that in mind. You're not supposed to sedate the child unnecessarily. Chest physiotherapy, they have no role to play in this scenario. And steam inhalation is another thing what has become a norm in many parents. It is of no use. The particles what are generated are more than 15 microns. They do not enter the terminal bronchioles and the last three airways where the medicine has to work. So it is again of no use. So with the COVID being in vogue, that's a thing what we have seen. But we must discourage parents from using steam, from using, what I have seen on a couple of instances is, they put those respicules into the steam machine and then they inhale that, which is of course no use. 36 hours later, you see Mahitha being very comfortable sitting on her bed. She has slept throughout the night. She hasn't coughed. She hasn't woken up in the middle of the night. And she is comfortable, talking happily. And upon your morning rounds, you go there and ask her, "Hi, how are you?" And first thing she asks is, "Can I go home?" So here we need to decide the criteria for discharge. On examination, her respiratory rate is around 24 per minute. She has a mild terminal wheeze, and at that time we need to lay down all the criteria. First thing is we step down our medicine. Last in, first out. That means discontinue terbutaline, aminophylline drip, discontinue ipratropium nebulization in 24 hours, reduce short-acting beta agonists from 2 to 4 hourly intervals to 4 to 6 hourly interval, and replace IV steroid with oral steroid. Making sure that the pulmonary score is less than 3, we need to consider discharge of this girl. So what is the advice which you want to give to this child when you are discharging her? We need to again have a written asthma management plan. Inhale SABAs as needed for a few more days, oral steroid for a span of 3 to 5 days, inhaled corticosteroids. So if already on inhaled corticosteroids, step up the dosage for 2 more weeks. If not on inhaled corticosteroids, double low dose inhaled corticosteroid should be started and then later tapered. So we need to review this girl after 2 days because she has come from emergency, gone up to ward and then to PICU, then she has been stepped down. So this is a case where she needs follow-up. So you ask her to come back in a very short span of 2 days. So at that time, we need to educate parents regarding the disease and its controller therapy. We need to educate the children about the disease so that they are aware of what is happening to themselves. We need to educate every child about the trigger avoidance and educate parents and children about the next emergency if it ever happens. I would like to thank the Indian Academy of Pediatrics and National Respiratory Chapter for majority of the inputs and the GINA guidelines where it has been heavily based upon. So thanks, stay tuned, stay subscribed, share this video as much as possible. We'll see you shortly in another video.